Good afternoon and welcome to the Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies Spring Webinar Series focusing on the behavioral health workforce. We're pleased to have you all joining us for today's webinar. My name is Christy Friedman and I'm the Program Manager for the Center. This spring series is co-hosted by the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health and will run as a 4-part webinar series from February to May of this year. Please save the date for our next event in this series, titled Changes and Constants in National Behavioral Health, which will be held on April 13th at 1 p.m. Eastern Standard Time and focus on the legislative and policy changes and their potential impacts on the behavioral health workforce. We have a wonderful blog post up detailing the genesis of this series and future dates to hold on your calendars if you visit our website at healthworkforcestudies.com. A couple of center announcements to be mentioned before we begin today's webinar. First, we've been working on a new Current Trends of Men in Nursing report that will update data we previously released in a 2014 data brief on our website. We will have new data on the number of men working in the nursing profession, minorities by gender, age by gender, hospital or non-hospital settings, and new degrees awarded to men in the profession. We are hoping to have this new data brief posted next week, so stay tuned to our website, again, healthworkforcestudies.com, for this information. Secondly, summer is right around the corner. Save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers Conference titled The Nursing Workforce and Health Reform, Trends and Opportunities in a New Political Era. This conference is being co-organized by our center and will be held June 7th through 9th, 2017 at the Grand Hyatt Denver in Denver, Colorado. More details, including sponsorship and registration information, are available on the National Forum of State Nursing Workforce Centers website. Their website address is nursingworkforcecenters.org. You can find all of this and more information at our center website, again, healthworkforcestudies.com. After today's presentation concludes, we will have 15 to 20 minutes for discussion and question and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We are also recording the webinar today, and we'll have it posted to our website. We have posted all of the previous webinars to our website if you've missed any of our previous ones, including ones in this series. You can also find presentation slides for many of the webinars posted within the Video Library tab on the center's website. Now, typically at this time, I turn the mic over to Dr. Peter Bierhaus, Center Director. However, he's traveling today and wishes to thank everyone for joining. As guest host, I would like to allow Angela Beck, Director of the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health, to take a minute and introduce our speakers. Angela?
Thank you, Christy, and thanks to all for joining this webinar, which focuses on what I think is a really critically important issue for behavioral health, developing the workforce pipeline. Before we get started, I'd like to quickly tell you a little bit about the Behavioral Health Workforce Research Center at the University of Michigan. We're a federally funded center that conducts studies on workforce size and characteristics. We do some work around analysis of scopes of practice for behavioral health occupations. We have multiple projects in process now. If you're interested in that type of research, please feel free to visit our website at behavioralhealthworkforce.org. You can find a summary of our projects there. You can download reports of our findings and so on. Okay, so today's webinar, we have two outstanding speakers for you today. First, Howard Liu is an educator and child psychiatrist at the University of Nebraska Medical Center. He serves as the Assistant Vice Chancellor for Faculty Development at UNMC and leads strategic initiatives in faculty educational and leadership development for the colleges of medicine, allied health professions, nursing, dentistry, pharmacy, and public health. He also serves as the director of the Behavioral Health Education Center of Nebraska, or BHECN, which is a state-funded office whose mission is to recruit and retain a skilled and passionate behavioral health workforce in Nebraska. Clinically, he maintains an active child psychiatry practice and is an Associate Professor of Psychiatry. Howard is a research partner and consortium member of our Behavioral Health Workforce Research Center, and he and his team have really been a tremendous help in the work that we do. Our second speaker today is Helene Silverblatt, and she is Director of Adult Programs for Community Behavioral Health, the Executive Director for Behavioral Health in the Office of the Vice President for Community Health, and a Professor of Psychiatry and Family and Community Medicine at the University of New Mexico Health Sciences Center. She's also an attending psychiatrist at the UPC Clinic. Dr. Silverblatt's areas of interest include rural and public psychiatry, cross-cultural psychiatry, interface between primary care and psychiatry, psychotherapy, family issues, transdisciplinary evaluation, adults with developmental disabilities, resident education in rural psychiatry, and community collaboration and involvement. So with that, I will turn it over to Howard to begin.
Thank you so much for that very warm introduction, and on behalf of BHECN, we're delighted to be here. And this is really an opportunity for us to share some information from a couple of states, but we think that the principles will actually apply to all 50 states and even some of our international partners, because we all have underserved parts of our country. So we're really just happy to be here. So just to start off, neither Helene or I have any conflicts of interest to report that are relevant to this presentation. And in case you're not from a contiguous state, just a quick reminder about where we are. Nebraska, of course, is part of the Midwest, and New Mexico is part of this Southwest corridor. And so we both represent different aspects of diversity, but we have strong rural components to our states. And we do have some urban areas, but I would say that part of both of our motivation to get involved really has been thinking about some of our rural partners and those that have very few providers. And certainly the aging of providers has also been something that we'll both mention a little bit as well. So I'm really representing a team at BHECN. I am a child psychiatrist still practicing clinically, as Angela mentioned. But really we have a team that includes folks that are skilled at legislative advocacy, education, training, and student coordination, as well as communications and so on. So really it's been a group effort. I mentioned that in our state we face really the challenge of what's called the gray tsunami at times, which is the aging of the workforce. Something that we've seen particularly is that over half of our current providers are over the age of 50. So what I tell all of our students is that they're going to have ultimate job security, because even those that are mentoring them now will be retired very shortly. So it really is a great opportunity for those to think about this. But for policymakers, healthcare provider organizations, and certainly the state, it's also a conundrum, because none of our licensed behavioral health professions can be created in 1 or 2 years. Some of these paths, like psychiatry, may take as long as 12 years after high school to get to ability to practice and licensing. So it really is a longer term a game, and really a campaign that's really should be run more like a marathon than a sprint. And you know, I'll also just point out here that for our state, addiction counselors are demographically the oldest, and certainly something that we're looking at very closely. So what is BHECN? BHECN is called the Behavioral Health Education Center for Nebraska, but I would say it really exists as a bit of a piazza or a common space amongst very like-minded entities who are all doing very important work in creating the future workforce. So we are state legislatively funded, which we do supplement with state, federal grants and some foundation grants, various projects. But I would say our close partners on the state level are Department of Health and Human Services, Division of Behavioral Health, and also the regional authorities for behavioral health. Certainly we work with provider organizations, and there's, in the state of Nebraska, certainly hundreds of them. We are based physically and somewhat philosophically in an academic institution, and that allows us to leverage training programs, which are really important for the future workforce. We certainly work with other forms of state government, including corrections, both at the state level and at the county level. And we certainly have partnered with many that are doing a lot of education and outreach as well to increase access. So I'll spend most of my time talking about the Ambassador Program, which is our flagship student program, which spans anywhere from as young as high school to those that are in graduate school already and also into practice. And it's important really to think about things at all of those levels. And I would say that, I think most of the attendees are probably in the behavioral health profession or perhaps are into policy. It's quite akin to recruiting someone that's going to be a future NFL player or any sort of selective process, whereas you just can't start the level just before. You have to really start at the Pee Wee football area to really think about getting a large base of people passionate and interested, and at each level having warm handoffs with mentors that can guide them along the way so they stay on the path. So here is our, I would say our trail of breadcrumbs. So it goes from high school into college to professional school, so it'd be like medical school, nursing school, and so on. Postgraduate, which would be like psychiatry residency, postdoctoral internships, and so on. And then those are into practice. We do continuing education both for current mental health and addictions providers as well as primary care, which everyone I think on this webinar knows is really the integration of behavioral health and primary care is one of the key factors shaping the future of healthcare delivery. So I wouldn't focus on this slide in terms of any of the individual programs, but I just wanted to show you that in terms of our investment, we certainly try to build a pyramid where it's broad at the base, high school and college, but increasingly, as you know, it gets more selective. And so we try to concentrate more resources as people move along on the path and are closer to becoming licensed, which for us is our biggest output. We also do collaborate with the state Department of Health and Human Services Division of Behavioral Health on unlicensed workforce, and they really have expertise on the peer professionals, and we do collaborate on other direct care workforce that are other unlicensed workforce. So what does it actually look like? So here's an example of somebody, and as much as possible, if you walk away from our part of the talk with one concept, it's that of multiple contacts, and warm handoffs. So Abby is someone that we've known actually technically since 8th grade, but in terms of BHECN programs since high school, and comes from a rural area of Nebraska. Mother is a science teacher in the high school, so obviously great in-home mentorship. And she first came to us in our rural high school conference, which we host for 2 days in the middle of Nebraska. And then she liked it so much that she then went to a rural college that was in northeast Nebraska, fairly close by. And then she really became very active. It helped start an Active Minds chapter, which some of you might know is sort of a mental health advocacy national group for college students. And then she became involved in our college conference, and then helped us pilot then with a state grant, the Rural Futures Institute grant, a virtual mentorship piece where we connected individual students with the profession of interest. So the 3 that we piloted in the first year were psychiatric nursing, also psychiatry, and then psychology. So here's a snapshot because Abby happens to be interested in child psychiatry. Of the 3 psychiatrists that we're mentoring, I'm in the middle, but on the right are 2 of our residents who were fantastic, and really we're doing the majority of the mentoring. And then the other side, the other folks are all just students that were participating from various colleges throughout the state. And it was quite helpful. We had 3 calls, over the course of a month, 1 week apart, and really tried to guide them through what to expect, how to prepare for an interview, and just advice to getting into graduate school. So it was very well received, and we're thinking about expanding that further. So we do a blend of live and online mentoring, as I mentioned before. And I'll give you 3 principles that we've learned over time, mostly by making mistakes, but sometimes by successes as well. I would say that the first principle is really being very specific with mentoring. So it's not just anybody that we're going to pull along on the bus to go to our rural high school conference and say, oh, can you sit at this table and talk? We really want to find people that are passionate about the community, As you know, many of these millennial generation future, well, certainly college students and future health profession students have a strong social justice, health equity interest. And so that for us is also just par for our mission, which is to serve the most underserved parts of Nebraska. And so we have a number of conferences, and here is just some examples. You know, North Omaha and South Omaha are quite underserved areas in Nebraska. North Omaha is primarily African American, South Omaha is primarily Latino. And so we host conferences there to introduce high school students to the concept of mental health and addictions careers. Kearney's the rural conference I mentioned earlier, and I think they've come from 70 high schools plus across the state to that conference to learn about that, and they stay overnight. It's a day and a half currently. And then we just added one in partnership with the SEPA program, which is Science Education. It's a federal grant for Native American students, and that one has been our largest to date. It's combined high school and college. But what I want to point out here is that although I'm certainly at each one of these, I am not the head of each one of these. You know, we really try to find, our philosophy is to find someone from the community, from the culture, that can actively speak about their narrative as to why they're, you know, passionate about the field, but also why they went back to practice in the community, and that's really important. So we always try to find those local guides to inspire the students and show them that they can come back and practice and be that access for their community. So the second principle is, you know, what level should you engage these students, high school, college, graduate, and so on. And my advice I've learned, again, just by making mistakes sometimes, is to make it challenging for students. As students want to engage their critical thinking. And so they don't want to sit there passively while you lecture to them. And even though panels are good, they're still kind of passive. And so, you know, what they've really enjoyed, we've discovered over time, are when they get to drive and they get to, you know, kind of shape the interactive experience. So, you know, the college conferences the last 3 years, I think now, we've added a simulated patient exercise where we hire actors, and then they come in and group teams of 2 or 3 students, they'll interview them, and then they have two scenarios that they'll interact with, and we don't tell them kind of what diagnosis that might be portraying or so on, but they try to discover that in these, I think, about 20-minute interviews as a team, and then we do debriefing afterwards, and they've really rated that very highly. And what we discovered was, you know, we gave them, the actors, sort of one diagnosis to illustrate the first year, but they said, you know, they wanted to see more complexity. So, you know, as we've shaped it, we've had comorbid diagnoses. No, it's not just depression, it's depression and PTSD, you know, and maybe sometimes you know, opioid addiction, that kind of thing. So, so I think we're trying to layer on things which are complex because they're closer to real life. And as you know, as an educator, fidelity to real life is really the lifeblood of simulation. That's how you know things are actually helpful, so to prepare people for the future, what they might encounter. And then the second thing that's been quite popular has been our table talks, where we have 15 minutes and then we ring the bell and you got to move on. But different tents, you know, and you go around, and we try to customize these to the interests of the specific conference, but very popular ones are always about suicide and anxiety, sometimes advocacy and so on. And people get to meet the providers and talk with them in a circle of no more than 6 to 8 students, and they really find that to be, they're probably the most valuable parts of our conferences. And I think you can vary those up depending on kind of what audience you're trying to reach. But they've always asked for more of that time. And because they're somewhat staff intensive, you know, we sometimes do have almost a one-to-one ratio of facilitators to students, so they really have the chance to have that interaction. So having the breadth of facilitators is really important. So this is just you know, an illustration that we have members that are consumers telling their story, and also talking about recovery, you know, for example, at these table talks and so on. So Bob Donlan's the individual on the left here, who's happens to also be a very gifted artist and has some background in theater, and has written a play that he performs and tells his story and journey with bipolar disorder and schizoaffective disorder. The middle picture is a photograph of Jared Langemeyer, who's a Douglas County sheriff, but sheriff's deputy, but also he's training actually right now in school to be a counselor. And so he shares the very real perspective of what does law enforcement encounter, and through training about things like crisis intervention training, mental health first aid, how they can be more informed in their approach when they're called to intervene or to evaluate a situation. And then finally, we have provider panels, and we think those are important just because students oftentimes don't have the language to know that, for example, psychiatric PAs exist, or that marriage and family therapists are different than counselors. So hearing from real people, hopefully from their communities, if we can find them in these panels, is really what they seem to enjoy. And we try to give everyone coverage and a chance to share why they went into their profession. So just some early outcomes. We've reached nearly 2,000 students through various career presentations, and more intensively, roughly 300 or so in high school and a couple hundred in college, and we have various pieces. We're actually right now in the process of distributing some grants around the state for others to do their high school conferences in their rural communities or urban communities, so that we kind of disseminate the model a little bit. Geographically, students have now come from nearly every county in Nebraska to our programs. And then in terms of graduate school, this has been a labor of love, but the last 4 years, we have increased by 2.5 times the number of medical students selecting a career in psychiatry, to the point where, I had a meeting with our dean of the College of Medicine yesterday, and he was asking kind of what's going on, is this, what's changed in the drinking water that so many people are interested in psychiatry. But I'll tell you that it doesn't happen by accident. And each one of those individuals, for example, we matched, I think, 15 or 16 this year out of a class of roughly 130, each one of those people was mentored. And some of them we've known for years, and then increasingly we've known some since college and so on. So really it's about continuity of relationships. We also are trying to be rigorous about being accountable to our various counties. And so we partner with the College of Public Health for our evaluations. And we maintain a real-time database of the counties and how many providers in each of the licensed behavioral health professions are in them at any one time. So, so you can see cumulatively we have that data over the years, and you can see what the changes are. Is it gone up 5% or down 6%, and what does that mean? So, so really have a chance for real outcomes and metrics about where people are going and where the evolving hotspots are. I'll just point out, without going into detail, that it's important that you can't just nurture people, but you have to help them find jobs. And actually, our communications coordinator, Krista Roberts, has done a great job partnering with the Region 5 Behavioral Health Authority to put together this statewide free jobs website, which has really gotten a lot of hits from both employers and also from job seekers. And we have a new agreement with basically all of the licensed behavioral health training programs in the state, that they're going to put all of their students onto this website. So for the first time, we're really going to have a true forum where everyone's going to be together looking for those jobs, the employers meeting the job seekers. And we've been lucky, and we really appreciate the opportunity to share some of our practices today, to be recognized a little bit. And the National Council for Behavioral Health last year did recognize us as sort of a best practice in training and workforce. And then earlier this year in September, we helped kick off for SAMHSA a webinar series for sharing state solutions on behavioral health workforce. And that was a partnership with also NASDAD and NASHBID and Annapolis Coalition and so on. So we really believe two things. One is that none of us has all the answers, and the second thing is that, but if you do have something, you should definitely share it. And so later on, you'll see in the presentation in the slides, which will be uploaded, that there are also a series of links that you can click on, and we certainly are open to anyone that wants to partner with us and learn more about our programs. And we'd love to learn from you as well. We know that certainly we only have a couple solutions, but we need to leverage the full wealth of the country on your innovations. So, and I will say too, in putting this talk together, part of the reason that Helene also is here in New Mexico is that they were our inspiration. When we were founded in 2009, Dr. Silverblatt came to testify for our unicameral legislature about the importance of pipeline programs, and I would say that that was instrumental. And so, you know, on my behalf, I'd say we're happy to pay that forward if we can. You know, if you have a state that's pondering the creation of a dedicated behavioral health workforce center or some sort of advocacy group in that behalf, certainly we'd be happy to give you a letter of support or to help you in any way we can. So with that, I'm going to ask Dr. Silverblatt, my colleague from New Mexico, to join us. So she is going to join us by phone, and I'm going to advance her slides for her. And so Helene, do you want to say hello? And let me just
yes.
And go ahead. I think we're just on your introductory first slide. 1 second.
So thank you very, very much, Howard, and Christine, and everyone for inviting me to join you this morning for the webinar. An interesting thing happened on the way to the forum, and that is that our internet went down. And it's a little bit of a lesson of what happens when you are very dependent on technology and then it fails, and you need to be creative in your solution. So I want to thank Howard for helping me figure out that we can do this by phone, and that he can help move my slides. But I think in some ways it speaks to how in the work we do, we have to be very nimble. I also want to say that your talk today, Howard, gave me a lot of ideas, and I look forward to talking to you more about maybe how we can partner in developing some workforce development. I want to tell you, next slide would be great.
Yes, go ahead.
Okay, so the next slide talks about the kind of historical reasons for how our program developed into one that was primarily one that looked only at enhancing behavioral health workforce in the traditional behavioral health environment, primarily focusing originally on psychiatry, to becoming one that looked at how we can integrate psychiatrists and other behavioral health providers into primary care practice. About 25 or so years ago, it became clear that there was a huge shortage of psychiatrists in much of our state. New Mexico, you saw the map and you saw where we're located, but New Mexico is the 5th largest state geographically in the country, and it's about 30-something percent, about 30 or so percent of its counties are rural or frontier designated counties. We have larger population centers in the highway corridor, I-25 highway corridor, but much of our state is stunningly beautiful, full of creative, full of this creative and diverse populations, but it's also fairly impoverished and maybe one of the poorest states in the country. The health equity issues in New Mexico are extraordinary. We have a huge need to be creative in how we think of things, and as a result, the medical school, University of New Mexico School of Medicine, and the Health Sciences Center, of which the medical school is a part, have really been nationally and even sometimes internationally recognized programs in innovation for healthcare dissemination and in medical student and residency training. When we initially got our grant to set up a rural training program, which continues and we hope it continues to be as successful as we think it is, it became clear that there was a huge need for support in primary care settings. And as a matter of fact, it was one of the primary care providers for one of our consumer partners in the development of the rural tract, which allows for residents to do rotations around the state in primarily their last year of training, that it became clear when we spoke to her primary care provider that she was doing all the mental health.
Hey, Howard, did we lose Helene? I can't hear her anymore.
Helene, can you speak up a little bit?
Speak up? Yes. Is this better?
Yes, that's better.
Thank you. That the behavioral health workforce, to be more effective, had to include not only trained psychiatry residents and psychiatrists, and as well as other behavioral health providers, but it had to include primary care providers, which included the physician's assistants and nurse practitioners who ran the federally qualified health center clinics, but that we could also enlist peer specialists who had received training and who were living in every community in New Mexico to be part of our workforce. In addition to breaking down the silos between primary care and behavioral health, it was also important that we break down the silos among all of our providers, between psychiatrists and psychologists, between the psychologists and social workers, and other licensed counselors. So our initiative became one to see where providers are located, where their clinical situation is needed, and how to enhance licensure for psychiatrists, psychologists, social workers, and others. Okay, next slide. Our first model for integrating primary psychiatric services into primary care was in a very small interdisciplinary clinic that's about 24 years old at the university hospital. And that was a traditional teaching clinic of the university. It was a family medicine doc and a resident, and an internal medicine doc and a resident, and a psychiatrist. That was me and a resident, and an OBGYN and a resident, and we had medical students across disciplines. We had social work students and staff working together in a sort of problem-based learning situation. It turns out that of all the different groups that were present, that behavioral health, our group from psychiatry as well as the social work group, were the most used. We were the ones that were in the most demand. So that felt good, but it was clear that we needed to expand what we did. As the psychiatry training program developed, we were able to enhance the number of psychiatry residents who were able to do their primary rotations in federally qualified health centers. That involves negotiating with the federally qualified health centers for things like space, access to electronic records, and negotiation about what the role of the resident will be. Will it be as a consultant? Will the resident pick up a panel of patients? How will the resident communicate with the primary care site in an organized way so that the primary care providers themselves, and they too were an interprofessional bunch, so that they too were more comfortable working with our individuals with serious mental illness, or individuals who had substance use issues, as well as the range of trauma and devastated communities that are devastated by poverty and other social determinants of health. From that initial integration, it became clear that we were having an impact on not only our trainees, but also on the clinics we were working in. And about 3 or 4 years ago, we were able to work out the scheduling, which, believe it or not, is the most difficult situation, so that all of our PGY2s, that's our postgraduate year 2 psychiatry residents, spend at least a month rotating in primary care sites. Okay, the next slide. And those sites are varied. In some of the sites, our primary care residents are actually working together with our psychiatry residents. And smiling at each other and talking with each other over concerns that they share make a huge difference in how people make their ultimate decisions. In addition to training our psychiatry residents with family medicine residents and students in the PA program, nurse practitioner program, and medical students, we thought that it was pretty important that our psychiatry residents learned about what psychologists do. Very frequently, there's a real siloing of, as you know, of behavioral health training, and that certainly can't be helpful. And it also creates huge barriers when it comes to understanding how we can work together and where our specific areas of expertise are. So we also created a family medicine program based out of the primary family medicine clinics at UNM, where psychology interns are present, as well as psychology attendings. So we have psychology residents, we have psychiatry residents training under psychologists, as well as psychiatrists, as well as family medicine docs. And we have psychology interns working together with family medicine residents, psychiatry residents, psychiatry attendings, and family medicine attendings. About 2 years ago, our psychology program that was based out of our Center for Rural and Community Behavioral Health received a HRSA expansion grant where they were able to provide integrated training for their psychology interns in rural primary care. This allowed for the psychology interns to have an experience that they usually don't get, which is to work outside of the traditional academic environment where they do their internships. And they were able to do rotations in tribal sites, primarily among Pueblo Indians who have clinics, general health clinics, on site. In addition to expanding to in this way, we feel it is extremely important that we respond as a team to what our communities need. And that's another way that we were able to take advantage of the innovations that are in place because of the need that we have in our state. We have a system of academic hubs where on-the-ground, community-based health educators or master's level providers or social workers are served as what we call heroes, which are health extension rural offices, kind of using the cooperative extension model. These heroes work with our AHEC centers, which is the Area Health Education Center, to expand the hub, which are community-based and grounded faculty are able to give us input back as to where the needs are. And we make an attempt to send our students and residents to those sites. We feel that community engagement only works when you are able to understand what your community needs. As a result of a lot of requests for more behavioral health training, as well as preceptor training across the board, UNM has recently set up an office for community faculty to coordinate undergraduate medical education and graduate interdisciplinary programs that are part of the School of Medicine and the Health Sciences Center, working with our regional hubs to create a system that is community responsive. The next slide, okay. In terms of recruiting people who want to stay, I think Howard and your team, you really hit the nail on the head. If you grow your own, you're more likely to have them go back and stay. But if we want to encourage people to work in community-based settings, that developing sites where communities themselves work together to develop welcoming programs for their students is probably one of the most successful tools that we've developed. And in addition to this data that looks great and we're proud of, I mean, the importance of continuing to show that our potential state leaders and our potential I'm sorry, I'm getting another call on the line, and I'm sorry that I disconnected it, I think. But in order to show that to our state funders, who we hope will add on to our training programs, that we are meeting their needs, one of the most incredible, I think, verifications of the success of our work has been the fact that we've had 5 providers move in the last year to a pretty isolated part of the state. We couldn't ask for a more successful outcome. The outcome was primarily successful because we spent a lot of time developing that site, working with local community organizations to set up dormitories for students who are living in the dorms of local community colleges, where they can work together in an interdisciplinary way, but they also live together in the dorms. They share ideas, they share their lives together, and as a result of that, we've had pretty successful outcomes, including support from local foundations and some increase, and at least a stabilization of state funding that we thought for sure would be cut in our currently drastic economy. Anyway, I want to thank you for allowing me to talk under such circumstances that are, not optimal, but I hope I was able to get across to you the need for planning and the need for innovation and the need for partnerships in creating the successes that we need to really transform practice environments and to ultimately improve behavioral health and general health. So thank you very much.
Great. Thank you so much.
Thank
you so much, Helene and Howard.
Oh, sorry. Go ahead. Sorry.
That's all right. Thank you so much, Helene and Howard, for great presentations. As I mentioned at the beginning of the webinar, we're going to be taking some audience questions, and we'll get to as many as we can. Please try to be pretty specific in your questions. Sometimes if you have a comment, that's great too, but if you can phrase it as a question or add a question to the end, that'd be even better. So if you'll go to the toolbar on the control panel of your screen where it says questions, you can enter those, and we will get to as many as we can. So I do have a question already for you. As clarification, can you describe what the MINE program is again, Howard?
The MINE program?
Yeah, M-I-N-E. I think you mentioned it towards the beginning of your talk.
You know, if I knew, I would tell you, Christy. But no, I'm not sure what that reference is. We talked about the ambassador program, which has several components, which is our pipeline program going from high school to graduate school. And there are some acronyms within that. I don't believe that MIND is one of them, but certainly maybe if there's a clarification.
Sure, we can follow up and circle back if the asker wants to clarify. First, how are you building diversity into your pipeline program?
Well, this is Howard. I learned a lot from Helene. She really has been a great mentor for us, and her work in New Mexico. You know, we went on a site visit 2 years ago, and Helene, I'm going to be back in town shortly, so we'll have to catch up. But I think there's an amazing. She mentioned this HEROES program, which is disseminated around the state, and New Mexico has some really trailblazing work with Native American tribes and groups, and that really has been inspiration for us. At BHECN's level, we try to have 3-year foci on different strategic areas that will increase access. So this year, in 2017, we'll be finishing up our 3rd year on school mental health as our focus, as a pathway to increase access for communities that often lack access to a primary care provider. But our next 3-year focus is really going to be on increasing the diversity of the workforce. And many of the listeners will probably be familiar with the federal class guidelines, you know, about delivering culturally and linguistically appropriate services, which we often talk about, but to do so, you need to have a diverse workforce, that's well trained. Right. And so it's a bit of a chicken or egg, and we're really going to try to partner with our state entities, our communities, to really leverage that, whether it's in Native American tribes, whether it's in communities that really have lack of access. North Omaha, primarily African American here, and South Omaha, primarily Latino population, and we're going to try to partner up with those community leaders. And all along the way, certainly whenever we are leveraging these 15 training programs in licensed behavioral health that are creating social workers or counselors, we're keeping a special eye out for those who are, represent some aspect of diversity, whether they're bilingual in Spanish, whether they come from a first-generation college attendance, whether they're rural, whatever it might be, underrepresented minority, that really can add to that richness of that provider population. But I wonder if, Helene, you can also comment on that, since you were really such an inspiration for us.
Oh, thank you so much. Well, the intention has to come from both sides, or all sides. And so we were committed as an institution to enhancing diversity because we are a majority-minority state, unlike I think there are only 4 or so majority-minority states where if we really want to have a workforce that reflects our population, we have to have a diverse workforce. And I think our chancellor, Dr. Paul Ross, was committed to having a workforce that was reflective of our population across the board. And that allowed for us to have an Office for Diversity, for example, that's very involved in pipeline programs throughout the state. But if the work is only going one way, and that is we're just doing, quote, outreach, unquote, there's a real danger that we are seen as these kind of visitors who are doing medical tourism we come out, we do our training, and then people leave. And so unless we really work from the ground up and use our community connections to develop programs and relationships, or I should say relationships and then programs, I think that we will not be successful. One of the things that's very crucial is allowing communities to see what resources we have that can be helpful. So, for example, in spite of the breakdown of our internet connections this morning, we have used telehealth to train providers who need licensure, who in the past were unable to get licenses because they were not able to get supervision. And this is true in throughout Indian country in New Mexico. About 10% of our population are Native American, and about over 40-something% of our population are Hispanic. And in these isolated rural communities, we have been successful in using Skype and other secure connections to provide supervision so that local providers then are licensed. Because we were able to get some of the licensing boards to allow online supervision or telehealth supervision rather than face-to-face supervision. Having a cadre of local providers who are on site, gives us a real leg up in terms of developing a diverse pipeline, because they themselves are the most, as you pointed out, Howard, they themselves are the most significant models, mentors, and influences that any middle school or high school student can have. They are in the community and they're successful. That is a very important thing to see. And we have to be flexible in terms of how we offer our resources. But we have resources that the rest of the state doesn't have, and it's our responsibility to share them.
Mm-hmm.
Great. I have another question here. How do you coordinate the collaboration of multiple universities across the different disciplines, i.e. medical schools working with bachelor and master degree schools providing social science type programs? Who runs point as the primary coordinator, specifically in the examples given where medical students are guided and mentored by psychologists and vice versa?
Helene, do you want to start with that, and I'll answer too?
Here's what the problem was. I could not hear the question.
Okay.
So if you could either repeat it or answer it, so I could sort of use you as a lead into an answer.
Sure. No, that's certainly fair. The question was, how do you coordinate the collaboration of multiple institutions, particularly when it's across profession? So, for example, given the example of psychologists sometimes helping to supervise medical students and so on, how does one coordinate that? Who runs the lead on that was the question. So,
okay.
Yeah.
I can answer some of that. Okay, thanks. I'm sorry, it's just
no, go ahead. That's fine.
So basically, I think it's important that, at least for us, the way it worked for us, is that we were able to develop a center for behavioral health that was, by definition, cross-disciplinary. Now, that took time, too, but it allows us to develop partnerships among the different behavioral health schools and colleges around, at UNM and around the state. So we have a regular team that needs to talk about behavioral health workforce development that is part of this state-mandated healthcare workforce program. That allows us to see if there are ways that some of the classes that we offer can be, that we can offer credits across the board. It is very difficult to get scheduling to work out, but the most important thing is to show that you are flexible around requirements and to get the buy-in from deans and directors of different programs. That is what has made our program successful, is the coordination within the University of New Mexico of cross-disciplinary programs and interprofessional education that is open to including non-traditional medical programs into their work in interprofessional education, to include social work, where, for example, we don't have a social work school at UNM, but there's one in several other institutions, or to include population health, or public health. It takes a long, the thing is, you need to start now developing the relationships and seeing where you can start out with pilot rotations, for example. Having social work students and psychology students work together in a community-based clinic where that may meet after hours so that there's no conflict with scheduling.
Well, those are some excellent points, Helene. I'll chime in too along these lines. I think the reason we called our high school and college and graduate school pipeline the ambassador program is that really you do have to be ambassadors across professions, across institutions. And I think your infrastructure matters. So I think earlier I showed a picture of our team. We're a pretty diverse team. But the team has evolved over time. You know, I happen to be a psychiatrist. But I really try to emphasize in our program decisions, you know, in our strategic foci, that is not psychiatry-centric, you know, because that could certainly be a blinder. And so, for example, we have another initiative which is going on, and it's a 3-year psychiatric nursing summit just on the state of the workforce, which is, you know, somewhat dire, you know, and we need to make sure that we really inspire a new generation of RNs, APRNs, DNPs, and so on to go into the profession. And so for that, we have collaboration with all the nursing deans from around the state and major provider organizations, state senators, and so on. Similarly, we often, you know, we have, you know, psychologists on our leadership team, but we also have a counselor as well, heading up our rural office, you know, and so having the right person be your ambassador to that community is really important. And then just showing, again, through both the awarding of what resources that you have, and then your political advocacy for things, you know, such as parity for you know, greater independence, for example, for different professions in the state, that you really are there for behavioral health writ large and not just for any one profession. And I think people pay attention, particularly if you get a legislative bill passed or if there's a resource piece that you're sharing like a grant, whether it's distributed. So I think the answer just goes back to diplomacy, and I think having a broad team, we have a very diverse advisory council as well as an executive committee that includes members from basically almost all of those professions that help to guide us.
Great. We have lots of great questions and running short on time. I was going to ask a question about what data you use to track, and do you have data on how many of your people that have gone through your program stay in Nebraska, and do you have it at the county level? So do they go back to the county where they hailed from usually, or do they go to other counties, or do you have any data on those metrics?
Is that a question for me, Christy, or for both of us?
That specifically was going to point towards you, Howard.
Okay, so I'll answer that very briefly. What we are tracking all of our students that come through our programs, but it's a long pipeline. So, you know, those high school and college students, you know, some of them aren't in graduate school yet. So and they kind of, there's a bit of drift, and the further your pipeline goes, the younger it goes, the more drift there is, and the chance they may not end up in a behavioral health profession. On what we have just partnered with 15 of the state institutions on is an MOU, a Memorandum of Understanding, that as part of you know, being part of this group, which did for us to support, give them some resources. They're going to go back at least 1 year, but hopefully up to 4 years, and share with us the current location and jobs of their graduates. You know, so that's a requirement. So we don't have that data in hand yet, but we actually this year, with that new agreement with 15 institutions or 15 programs, will have that data for the first time, and it's really important. But the general mantra holds true. that where you train tends to be where you work. So if you want people to work rural, you want to train them rural. If you want them to work in FQHC, you want to train them in FQHC, and so on.
Right, great. We hear that a lot and across professions too, so I think that's definitely becoming a truth. Well, we are at the end of our time today. Angela, do you want to take a second and just thank our speakers?
Absolutely. Thank you so much, Howard. And Helene, we really appreciate you working through the technical issues to bring us all of this important information. So many thanks to you both for your participation in this.
Great.
Our pleasure. Thanks so much.
Yes, and thank you very much.
Thank you so much. It really was a pleasure, and I hope that if people have comments or questions that they can contact me without a problem.
Yes, we did have contact information up, so some of these great questions we didn't get to, I'm sure they'd be happy to respond offline to those requests. So that will conclude our webinar today. Again, thank you so much to our speakers and everyone who attended today. And be sure and save the date for our next event, Changes and Constants in National Behavioral Health. That'll be held on the 13th of April at 1 p.m. Eastern Time, focusing on legislative and policy changes and their potential impact on the behavioral health workforce. Thank you so much.
Thank you.
Thank you very much.
Thanks, Helene.